Hi friends, today we'll be discussing related to the ophthalmology part of our paper under RGUHS. So this is what the pattern they have given. So if you see broadly, these are the topics on how they are divided. So if you see, these are the major 10 marker part where you can expect a 10 marker question that with this, okay. Then you have 6 marker range of these three things and 5 marker ka topic and 8 mark with all the other things. So if you see, this is how so these 10 topics have been classified accordingly based on Singhi and Kurana. Okay, so under your Singhi or under your Singhi, conjunctival disorders fall under 5th chapter, and corneal under 6th, and glaucoma falls under 10. And this is how the remaining things goes. So I have classified the remaining part under miscellaneous. So this is how the Singhi classification is according to the RGUHS pattern which they are given. This is the exam pattern and marks weightage what RGUHS has given. So based on this, let us predict the paper and follow the same narration like how we did for other subjects. Okay, so if you see here, again, long answer question can be either from conjunctival disorder or corneal disorder. So the important questions from conjunctival disorders include VKC, okay, and from corneal disorder, the major thing which they are asking is fungal coils. More important than all your other acanthamoeba, okay, then bacterial ulcer, all those things. Okay, yeah, VKS is the most important 10 marker which they can ask. And one CBQ is sure either in first question or a second question. One CBQ is sure according to our recent RS4 pattern of CBME. So based on that, one glaucoma question, it might be primary open angle glaucoma or secondary glaucoma, something related to that. Or if they want to ask, they might ask something related to retinal disorder. For example, progression of diabetes mellitus or hypertension. So something related to that is asked, especially if they're asking something related to retina. One sub question will be causes of loss of vision. Okay, one sub question with a case with audio classify and audio manage is the basic outline of an LAQ. Okay, so coming to 5 marker, so one question related to your refractive errors, it might be either myopia or your astigmatism or hypermetropia. Though these are the most important things, astigmatism is the one thing with one question which is being asked consistently. So make sure you study astigmatism in a detail. I mean to say in perfect. Then either you might get a question related to aphakia. And one common related question is sure, something related to vitamin D deficiency or trachoma, which is also covered under your corneal or conjunctival disorders or something related to your legal blindness. So one common related question is a sure. And one question related to your cataract about some, basically they are asking you after cataract or surgical complications of your cataract, that one question related to cataract is sure. Okay, then again based on what was asked for 10 marker, these two are the next two questions which you can predict. Either they might ask you conjunctival if corneal was asked, or they might ask you corneal if conjunctival was asked. And also based again it goes with the same narration, part 2 of the 10 marker is being expected as one of the 5 marker in part 7. Okay, according to recent trends, they have now also started to ask about the physiology related question, for example relating the pupillary pathway or some things. Okay, and also one question related to eyelid, for example blepharitis, posterior blepharitis or chalazion or something related to that is being asked. And orbital disease, for example fractures or something related to that is asked. And one question related to your trauma or endophthalmitis or lacrimal drainage system, that is DCR indication for 3 marker or 5 marker they can ask, or something related to chronic dactylocystitis. Okay, so these are the predictable questions. Okay, now coming to short answer question. One question related to anatomy is for sure. For example, they might ask you about extraocular muscle. For example, they might ask you about nerve supply. So something very basic is for sure. And one question related to iridocyclitis or uveitis. Okay, either this might come as a 5 marker replacing this or this. Okay, or they might it can be asked as a 3 marker question. And two questions something related to your basic science. I know I have told anatomy as the basic thing, but here common related things is being asked in and out. And also one question related to pharma. For example, here I have asked most repeated, that is anti-glaucoma side effect can be asked. Okay, and next two questions are something related to classification or types or etiology, something related to neuro-ophthalmology and strabismus under this. Okay, sorry, under this part. Okay, this is what being asked as one of the questions. Okay, then again one question related to tear film. Okay, that is something which they will ask. For example, what are the composition of tear films or something related to that. And one question related to indication, contraindication based for any procedure or eye bank related things they might ask. Again, what is the aim of 3 marker in the surgical topic? To test about your pre-para and PSM related and surgical instruments or surgical procedure ka indication, contraindication. So if you know that, if you know the flow, I'm sure you can attempt all the 3 markers. Okay, so this is how it goes. So based on this, let us jump to the topic and discuss accordingly. Okay, first topic, first let us finish the most important thing, that is conjunctival disorder, which is a probable 10 marker for the first question itself. So firstly, we'll see the first I hope you have the first, if you are feeling it difficult, have an anatomical variation before studying ENT and ophthalm. Okay, so based on that, now when you place the disease, all the diseases will fit accordingly, and so that you can study properly. Okay, so these are the 10 markers which they have asked, these are 5 markers which they have asked, and this is the 3 marker. Okay, so based on this, let us have a narration of conjunctival disorders. So what is the major thing in conjunctivitis? So first let us discuss what are the diseases. So basically here the major things what we have is infectious. Okay, and one more important thing is it's about the outgrowth, which is nothing but pterygium. So these are the only broad 2 topics which you need to know. And also in other topics I have discussed, the only thing which we need to study extra apart from the general medicine, general core medicine ka topic is pterygium. So we'll see out that is one important thing which is differentiator. And trachoma also, because now also already we have eradicated trachoma according to WHS, so that is also one of the important topic. And subconjunctival hemorrhage as a easy narration, because every system, every paper we have one question related to bleeding. So I have discussed accordingly how we have to write and present the answers for that. So again, remaining all is either allergic bar, infectious. So this all should have an easy narration, because we already have a proper understanding of how an infectious protocol goes. For example, how will be the clinical feature. Again, the same path related things like tumor, cala, tuber, all those things you can write. So that is how you write in the general thing. So here, since we are discussing related to eye, so you need to understand the anatomy part of it. So based on anatomy, let us add itis to all that, so that you know how the complication goes and also how everything falls into picture. So based on this, now let us discuss about the classification, because for any disorders, classification is the mother of understanding the whole concept. Okay, so based on the etiology, again as I told, it might be either infectious or non-infectious, majorly because of allergic. So again, if it's infectious, then obviously you can write all the infection. The major thing is about the trachoma thing, which you need to know as a basic community health program. Okay, non-infectious, majorly it's about allergic. Okay, so it is also again VKC, it's something important. What is phylonecular? See here, I know ophthalmology is all about knowing names, correct? So one who understand the one who understand the meaning. Okay, the etymology part. What is etymology? It is nothing but knowing the meaning of it. So if you know this, then you will understand this. Okay, then you will understand the meaning of the name, so that you have an easy connection. So you will understand what as the person who has what is the person trying to say by that name. Okay, so again here obviously what does angular has to say, this is something which I'm sure you will know, but what does phylonecular has to say? So whenever you hear this term, then you have to think about only chronic disease, for example TBs or CORD. Okay, what about this angular? So it is based on the inner canthus of eye. So here most of the this is one of the other presentation of bacterial. So if you know this, so whenever you know the protocol, when you have the normal infectious disease template which you can write, but here you have to fit some other things, so that you remaining things remains the same. So based on this, let us dive into VKC first, because it's a short end marker. Okay, again, etiology, obviously it's allergic part, so you have to write about that. Then again, while writing clinical features, make sure you write it accordingly. So since it's something related to eye, obviously I have to talk about ocular symptoms and also discharge related symptoms. And also what is the major, so when I'm writing about conjunctiva, what is the functions of conjunctiva? So if you know the function of conjunctiva, first thing is to keep it moist, eye moist. And also it is a can also affect vision because it's a covering of cornea, and also because of irritation you might have a discharge also, so make sure you present it accordingly. Okay, then these are the signs which you need to remember. Again, the important thing I have boxed it, that is honor transports. Okay, that is one which I have to write. Again, coming to the aims, so you have to write about symptomatic relief. This is the important thing. Again, what is the major thing which you have to know, the how does the major this thing goes. First you have to start on olapat, that is olapatidine, which is an antihistaminic. Then you will start on steroid. If it's not responding, then you will go for tacro. So this is how a normal person understanding is. So if you write this, how much marks you will get for 5, 2 or 1? Okay, but how will you place it now? So for example, now you will based on how do you give a symptomatic relief. Obviously, we will write about all these things. Then how will you control the inflammation? Again, if it's a short term, you have to give steroid. Long term, you will give tacro. To prevent complication, again, what is the major complaint is a itching, so you have to give lubricant. Again, to prevent recurrence, you have to avoid the exposure. Again, always it's very safe to mention about treat secondary infection if present with antibiotics. Okay, again, while writing complication, what did I say? Imagine the anatomy. So you can press first, write this, then this. Again, third thing which we have discussed here. Then also a treatment related, which many people miss, but if you write it, it's very good. That is steroid induced glaucoma. Okay, that's it. Then that's it to know in VKC. Okay, so then coming to the phylanectola conjunctivitis. So what does phylanectola means? That means small localized nodules. So whenever you see, it's a delayed hypersensitivity response to endogenous allergens. For example, it might be seen in TB, sarcoidosis, or those things. Then these are the types. Okay, it might be simple, or it might be dot 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 dot, or in the ring, or it might be large nodules. Okay, so if you know it, then you know how to place it. Again, clinical feature is same for all conjunctivitis. That is the importance of knowing the basic clinical feature of any infectious. Okay, then these are the signs. Almost it goes with the same thing. Then again, what is the management is almost the same for, but extra thing which you need to work up for is TB or parasitic infection. Okay, again, what is angular conjunctivitis has to do? Again, everything is same. The extra thing is what I am discussing here. This is because of the location, bacteriological or mainly find in the lateral canthus. Okay, so again here one important thing is you have to prescribe a tetracycline, that is antibiotic for part of it, and also you have to treat associated blepharitis, because where is it happening? In the canthus. Okay, the intracoma, in and out is important. Okay, so what is it? It's a chronic keratoconjunctivitis is something you have to remember. Again, serotypes can be as per MCQ. These are the clinical features. If you want, you can present like this, but I would like to prefer a WHO Fishto's classification. What does Fishto has to say here? What is first? Follicular inflammation. This is intense inflammation. What is this? Again, is for superficial scarring, trichiasis, then corneal opacity. So if you know this is the same clinical feature. If you can follow. Again, early is nothing but follicular inflammation. Then established comes under proper intense inflammation, and cicatrization is nothing but scarring, and again cicatrization involves scarring and trichiasis. Then again complication, you can write the same thing, but Fister, it can be in the independent question for 3 marker itself, so make sure you study accordingly. Then again, while writing complication, as I told here, one important thing what people forget is about the lid. Okay, well, lid is something which you have to remember. Again, safe protocol is what they might ask in the community level. So what is S stand for? S stands for surgery for trichiasis and entropion, and also antibiotic, that is acetro. Okay, then also other to this facial and environmental cleanness. These are the management. People will forget about prevention of complication and how will you eradicate. Again, you have to write about environmental hygiene, that is fly control and health education. See, what do they expect you to know from a basic MBBS graduate is what you are expected to write. They don't expect you to write management protocols for 3 pages. The maximum page you will get for a 5 marker is 5 page, that is including first and second page, and for a 10 marker, for a 5 marker is just 3 page. So 1 to 2 page is what they're expecting is about the etiology and clinical feature. Here at an MBBS level they expect you to diagnose things, not to manage everything. Okay, so make sure you know that. And management, even if you write so much, it should be enough. And what does ophthalmia neonatal has to say? So something related to eye in the neonate. So what is happening again? The conjunctivitis, because we are in conjunctiva still, correct? So these are the class etiology, and these are the same thing, but here you will have chemosis and swollen eyelids. That's one important thing which you write. And also one important thing is about the prophylaxis, which people forget here. Please, while writing management, it's not only about treatment which you are talking. Already you might have passed study here, but PSM should be always there with you while writing prevention. So these are the ways how we will prevent. Okay. Then again, obviously it's an infection. So based on what is the causative organism, you have to start on antimicrobial therapy. And also this is the local eye care which you will follow. And also if there are systemic infection, you have to evaluate for that also. Then pterygium is something which has a different narration when compared to all other things. Okay, so what does pterygia has to say? Pterygia means wing. So what does it mean? So if it's an eye, so something related to that in the nasal side. Okay, that's what important thing. Okay, so again, clinical feature, what is the important thing? Obviously your vision is getting affected. So what is the important clinical feature you have? You might have astigmatism. And also one more cosmetic thing is also something which you can mention. Okay, management, again you have to completely exercise. Okay, exercise, but what is the major problem? You might have a chance of recurrence, so you have to give mitomycin. Okay, and also you have to treat any secondary infection. Okay, that is. And also about the, see, one important thing in ophthalm is there are few things where you can write treat secondary infection, and to control inflammation you can give atropine, that is cycloplegic, so that it doesn't act too much. So make sure you know where to present this so that you won't. And also lubricants. So any management protocol you can safely include this, provided you know where to include. Again, now all the 3 marker part of it under conjunctiva, these are the things which they can ask. Again, what are the causes of red eye? When you write that, make sure you classify firstly into painless and painful. So when it's painful, what are the causes? It might be painful diffuse eye or congested. Obviously this everybody will write, but what is the cause of painful diffuse eye? That means something related to nerve is getting affected, so you can talk about scleritis. Then again, painless, obviously it's something to do with pterygium and episcleritis. Okay. Then again, if it's a diffuse, obviously you can talk about nephritis and all those things. Subconjunctival hemorrhage. So one important thing is always remember this and this, and also this. Okay, two things which and also obviously trauma also is something people might remember, but spontaneous something people will forget. So make sure you study this, because this, again, hemorrhage, what did I say? Systemic, drugs, everything. Okay. Again, this is the normal management course, but this please don't forget. Again, what is the surgical indication in the subconjunctival hemorrhage? To give a decompression. Okay, that's it with conjunctiva. So it has a easy narration. What is the major important thing which you need to learn in conjunctiva, which has a different narration? Pterygium. Yeah, expected. What are the questions which are expected? Again, the same infectious protocol, infectious pattern which is there. Again, write the same clinical feature for all conjunctiva, except which you need to underline, which I have already presented, and also examination features, and also complication goes the same. Management differs for only for a phalanectoral conjunctivitis, where the major management protocol is to detect what is causing phalanectoral conjunctivitis. Okay, then also what is the important thing, so you will underline it. And also while writing management, make sure you write the aims. Here investigation is less because you are just putting an infection and it's already there. Okay, major thing is about your management, and I also told how the narration goes. Okay, with that background, let us come to corneal disorders, which is also an expected 10 marker. I don't know how many times they have asked about fungal ulcers. In and out of fungal ulcers is important. Okay, and again, this as a part of 10 marker they have asked. So if you are feeling it difficult to remember carotid. For example, what are the 3 organ pathogens which can invade the intact epithelium? It is Corynebacterium diphtheria, Neisseria meningitis, and Neisseria gonorrhoeae. And again, this is the same Robin's pathogenesis of any infection. Because here, what is the major thing? Again, if you know, it causes infiltration by neutrophils. Again, this might cause an overhanging margins. Again, this slough will be removed. That will cause us what? Cicatrization. That is nothing but scarring. Okay. And again, here the same thing. See, is it not? It's the same thing. Conjunctiva and cornea has the same clinical feature. Okay. But while writing complication, again, you can write one more important thing is what will happen during, before, during, and afterwards. After your disease. So this is a, I've just presented. Make sure you study it because it has the same thing. Again, how do you prevent it's a bacteria? Again, you have to do GM-STAR staining or gram staining. Again, how will you treat uncomplicated? So what is a complicated? That means it's already under surgical thing. Okay, but if it's an uncomplicated thing, obviously you have to treat infection, and it's a fungal. Please, so this bacteria and fungal I have clubbed for an a thing that they will ask you mostly bacteria. So a CBQ can be asked. So how does a CBQ will go? A vegetative maska trauma. If you get something related to this question, a vegetative maska trauma, blindly write fungal also. Okay, blindly. Though there are many different, though there are not many differential, 100% it will be something related to fungal also. Again, write the same things. Okay, don't even write anything further. But the important thing which uh, is differentiated from bacterial fungal ulcer is again the fungal ulcer ka extra treatment, which is the most common cause. There is aspergillus. Okay, so you have to talk about natamycin and candida. Again, atropine and steroids, as I told you, it has the same thing. Again, if there are any other existing condition, for example, log ophthalmos or chronic ductal cystitis, you need to treat that. That's it. See, if after is easy, provided you know how to study all things under one general thing and provide a specific thing what they ask in a box. If you know that, you are sorting out after. But if you start studying everything in a separate way, then you are in big trouble. Okay. Now coming to the second thing, that is hypopyon ulcer. So what does hypo means? Hypo means obviously below. What does pyon means? Pus. So where is it below? Pus is in anterior chamber. The anterior chamber, if it's settling below, then it's called as hypopyon ulcer. Okay, when it is associated with corneal ulcer. So this is the etiology, and these are the types. Either it might be due to bacterial or fungus. Okay, again, what is a big thing which is a differentiator in the mycotic thing? One important thing is immobile and thick. Okay, but here it is the same. Okay, and shift with procedure, and also examination findings I think I have missed here. So one especially related to fungal I will talk. Okay, you have to write about serpiginous ulcer and satellite nodules, and also fixed hypopyon. And also one more ring is there. That's an immunological ring. Make sure you write all these four because this is an important question, man. This should or will come. Okay. So make sure you study this part in and out. Okay. Complication, if you want, you can just this can be a 2 marker or a 3 marker. I won't expect you to know everything, but management and investigation and clinical feature and examination findings in and out you should know. Okay. Again causes of non-linear ulcer and how do you go? Obviously it's a majorly a surgical thing. Okay. I can't remember again here if the CBQ has to be asked. Again, something to do with swimming they might ask you, or about contact lens they might ask you. Okay, make sure you know how do you identify a diagnosis, how do you come with a diagnosis. Again, clinical feature is the same here. Severe pain out of proportion. Again, one more important thing in the fungal thing, what is that? Science is more important than clinical feature. Okay, a patient will come to you because just of ulcer he will not even have pain. But in acanthamoeba keratitis, the examination findings would be less, but the pain will be intense. Okay, that is an important differentiator thing. And these are the things which where you have to put it in box and present to the examiner that you know this. You have to show that you know this. Okay, then again these are the signs. Again, complication you can write the same thing. Again, how do you do? Again, the same diagnosis protocol which you follow for all your amoeba things. Okay, then again you have to eradicate both trophs and cysts with these things, and also you have to give cycloplegics and you have to prevent complication. This is how it goes. Again, if you have landed in complication, again you have to do keratoplasty. Okay, then again coming to deep keratitis. So for that you should know what are the layers in cornea. So okay, before that let me take up what are the layers which are present in cornea. Okay, if you are feeling it, again first important thing which you can remember is epithelium and endothelium. Okay, epithelium is outside and endothelium is inside, so it forms a barrier function. Then again remember B, C, D. Okay, C you just write one more C, ulta. So what are the 5 layers? Again I have told, first remember epithelium and endothelium. Epithelium is outside, endo in, N and N, right? So inside. Then again ABC. Again second one is Bowman's membrane. Third layer is stroma. Next layer is Descemet's. So again, now remember the functions of it, so that you know what are the layers is being affected. What are the next? What are the function of epithelium? It's a barrier. Bowman's membrane also it's a barrier. But what about the stroma? It provides you strength and transparency. But after that, you need an internal elastic membrane to for a durability thing. Okay, then what does endothelium has to do? It has only to do with dehydration. Okay, one that itself, this itself is a three marker. There is a reason why I'm discussing this question at first, and then going to other topics of cornea, so that you have an easy understanding of all the disease. Okay, now again they might ask you about what are the factors which affects transparency. Okay, these are the physiological factors. First divided into physiological and anatomical. Again, avascularity, relative dehydration, and the arrangement of corneal lamina, the other important things which causes uh, transparency of cornea. So basically, what is happening in an ulcer? These are the layers which are getting affected. And what is happening in the case of interstitial or deep keratitis? This is getting affected. What happens when you are doing a keratoplasty? Again, you will go here. There's something called as full thickness keratoplasty and partial thickness keratoplasty. In full thickness keratoplasty, what you are doing? In full thickness keratoplasty, the important thing is you are replacing all your five layers. So that is nothing but full thickness keratoplasty. But there's something called as partial thickness keratoplasty also. So partial thickness keratoplasty is something which people won't understand, which people don't study much in the UG level. So what does partial thickness keratoplasty has to do? So if you are just replacing these two, it has a specific name. If you are just replacing these two, it has a specific name. So that is something to do with partial thickness keratoplasty. Full thickness keratoplasty, so you are replacing all the layers of cornea. Got it? That's it. And also again, ulcer part which you have to know. And also one more thing which people forget is about the keratoconus, where you'll have U-shaped cornea or bulging of cornea. These are the diseases which are there in cornea. Now fit it in the disease and place it and study it accordingly. Got it? So now we know that. So again we have finished our a fungal part, parasitic part, and also bacterial with the clubbing, right? So now we will go to the next part, that is interstitial or deep keratitis, which is affecting a Descemet's membrane. Correct? No, that is stroma of cornea. So what are the causes? Again, you might have allergic cause or an infectious cause, like how they are conjunctiva cause also. Again, clinical features, as I told you, it's the same thing. Signs, what is the important thing? Salmon patch. So this is how you have to study. Now we know the basic anatomy. Now we know what does the disease affect. Now we know the clinical features also, which is the important thing, which differentiate how you need to draw a clinical feature based on the basic etiology of the disease. Now based on that, these are the stages. Again, treatment is same. If it's again it's affecting deeper part. So it has to do with something related to systemic part and a chronic disease. So obviously it might be either chronic systemic disease like TB and syphilis. So what is the treatment of that? Do that. Again, other treatment principles remains the same. That's how that's how it ophthalmology is provided. You study it accordingly. Okay. Now again, for excessive keratitis, what is the important thing is first you need to know what is getting involved. As I told, cornea as an epithelial layer and the stromal endothelial stromal part, right? That's how broadly we divided even for partial keratoplasty. So based on that, either you might have epithelial keratitis or stromal keratitis, broadly. So now based on how the pattern of ulcer, again epithelial keratitis can be either punctate, okay, if it is involving the epithelium part. So first you localize the lesion where it is. Second, recognize the clinical pattern. Okay, if it's dendritic, then you have one more thing. Then if it's an amoeboid, then it's third part. Again, stromal, it can be either diffuse or disciform. Okay. So again, these are the stainings which you do, okay, rose Bengal stain and all those things. And what is the treatment? Obviously, acyclovir, and also you can give trifluorotan. Okay, so same viral disease ka protocol. So you also know how to remember a classification, and obviously you know the pharmac and micro part. Where is the toughness coming? It's not. So basically, problem arises when you start dividing things. When you unite things, everything becomes easy. Provided you know what is the expected thing they are expecting you to know. Then exposure keratitis, again they might ask you for 3 marker. Again, I'm sure you know about the etiology, MG and Bell's palsy, I'm sure you know. But again, thyroid disease and lag of thymus is something which people forget, and also hydrogenic. You can just remember. Again, what are the goals here? Major thing is you have to do this, okay? Artificial tears and lubricating drops, and also if there are any secondary infection, treat it. And also treat underlying cause, for example, Bell's palsy. You have to give prednisone 2 mg per kg body weight as a steroid. Okay, then what is the complication of corneal diseases? One of the complications is adherent glaucoma. So what is happening? The cornea which is there is getting incalcinated. Okay, so that is nothing but leukomatous opacity, which is the all the layers of cornea is becoming adherent. Okay, that's one thing which you need to know. Again, how do you manage? Obviously, it's a complication. The mainstay is what? Surgical. Whenever complication arises, obviously it's a surgical topic or surgical paper. Obviously, the main management will be a surgical. Okay, to relieve symptoms and pain, you will do all the other things. Okay. One more important disease is keratoconus. So what does kerato means? Again, conus means what? Cone. Kerato means cornea. So cornea is looking like a cone. So what can be the etiology? Obviously, there is any congenital weakness to central part of cornea. So again, what is the major function of cornea? As I told, refraction. So what is the major clinical feature the patient will present with? Myopic astigmatism. See, that's why knowing anatomy physiology is so vital to any clinical subject. Okay, and again, these are the signs. What are the important things which you need to write about? A monsoon sign and watch and Flesher's. So place it accordingly and come back. That's it. Again, what is the important thing? Again, when you see down, whenever the patient has a down case, then when you can notice this V-shaped thing, that is called as monsoon sign. And these walk stray and Flesher's lines are self-explanatory. Okay, and these are the investigations. Again, oil droplet sign is something which is one of the name thing which you need to remember. Again, you will do, since it's a corneal thing, obviously you have to check for the thickness of cornea, by which you can do which you can check by pachymetry. Again, these are the treatment. Obviously, if it's progressing, obviously you need to prevent the progression by cross-linking the collagen fibers. Again, obviously you have a refractive error, that is myopic astigmatism, so you have to provide glasses, and this is the surgical treatment which you need to do. Keratoplasty, I have discussed what are the types, and these are the indication. Obviously, there might be a therapeutic indication or a structural indication. So this is not there, less done, but this is the major thing. Okay, and also optical indication. These are the contraindication. Okay, if there's corneal vasculation, obviously the function of cornea is gone. And if there's no sensation of cornea, what is the point of putting it? These are the contraindication, and these are the complication. In layers of cornea, I've already discussed. In corneal edema, so while understanding the concept of corneal edema, so what is the important thing? Cornea is a relatively dehydrated structure, so edema can occur majorly in the endothelial part or the epithelial part. And what are the other causes of edema, which you know? That is inflammation, and also due to mechanical cause. So you know, these are the two main structures which maintains the relative dehydration part. So if this is getting affected, then obviously edema will be formed. So based on this, now place the disease. So what is the major management part? Obviously, you have to remove the water by using an hypertonic solution. What is the hypertonic solution which we have? Hypertonic saline. Correct. So that's how it goes. Again, corneal opacities. Again, remember these are the three important things. Again, the adherent glaucoma is the last stage. So what are the major things? Nebula. So that is faint haziness. Macular is moderate. M for M. And leukomatous, which I have already discussed. Again, what is the major thing is you have to do a surgical correction for all these complicated things. Cornea is done, conjunctiva is done. Okay, so you are understanding how easy it is, provided you study in the orderly ways. The aim of this video is to make sure you study in an orderly way so that you don't lose marks. Again, these are the 10 markers, 5 markers and 3 markers for your glaucoma part of it. Again, before starting glaucoma, they might ask you about gradual loss of vision. So to have a normal vision, what are the physiological things which you need to have? One thing is, obviously you need to have a lens. Okay, one more important thing is you should have a perception. So for that you should have an optic nerve. For that you need to have a disc or retina. Okay, for even if lens is there, what is the much important thing which you need to have? Refraction. So these are the causes of loss of vision. Now what are the causes of gradual loss of vision? If you ask me, these are the causes. CRA or CRVO is sudden loss of vision, but gradual loss of vision is ARMD and DR. What is ARMD? Age-related macular degeneration or diabetic retinopathy or retinal dystrophies like retinitis pigmentosa. And these are the optic nerve causes. For example, chronic open-angle glaucoma or senile cataract. And these are the refractive things. Again, here we have discussed about chronic open-angle glaucoma. Make sure you know the definition properly, because what is the disease? Again, people will talk about IOP. Whether increased IOP or is diagnostic of glaucoma? No. Optic nerve damage is something which people forget, but optic nerve is the major thing in glaucoma. What is the sequelae of a glaucoma? It will affect optic nerve. So make sure you know it, okay? And these are the causes. and risk factors. So what is the important thing which you need to understand is it's a chronic disease. So if you write acute symptoms, you are fail. That means you are out. Okay. So again, gradual painless peripheral vision loss, because they have asked in the clinical CBQ itself. So I have mentioned, but major two things which you need to mention is difficulty seeing in dim or late night, and frequent change in presbyopic class. Please let me be very clear. I am saying it's presbyopic class, but if you are seeing other class, then what is the major cause? That is cataract. But you have to mention presbyopic class. So I am highlighting what are the things which you need to say. Okay, these two things you will mention, and also this is major thing you will mention. But one minute you mention nausea, vomiting continuously, how will it's a chronic disease like diabetes or hypertension, so you cannot mention that. Again, you have to mention this word occasionally while mentioning about those things. Again, these are the signs. Okay. Again, tubular vision as a clinical feature only I have told you. Again, these are the differential diagnosis. Again, what is the major investigation scheme? That to detect whether there is elevated IOP, for which you will do gonioscopy. Without doing gonioscopy, if you do tonometry first and do gonioscopy, obviously you get false positive. So you have to write the investigations also accordingly. So if you have attended your clinics, you will see first they will do a gonioscopy and check for the anterior chamber cut diameter, because that's like a first thing which you do. Then you remember with the then you check for the IOP. Okay, then you assess the corneal thickness by a pachymetry. And what is the next thing in an investigation we write in all the subject? Look for complication. What is the complication here? Optic nerve damage, correct? So I have to mention about the optic nerve damage also. And again, to assess visual fields because of optic nerve damage, we do a perimetry. And in how does perimetry gets affected based on your this thing. First affects nasal sign, then you'll have paracentral scotoma, then you have arcuate. What is arcuate means? Arcuate line, okay. Something crescent shape. Then you'll have tunnel vision, then you'll have total field loss. That's it. Then these are the general principles which you need to do. It's a lifelong therapy. Again, what are the major things which you need to do? Again, it's a chronic disease, okay. So how you can remember is, for example, remember you have a sink, okay. It's draining, but you have some clots. So draining efficiency is reduced. So this is one important thing which you should know. Okay. So if you know this, then you will know how to write it. So these are the management goals. So major thing is, obviously there is increase in IOP, you need to reduce that. Then also you have to prevent optic nerve damage, and also you have to preserve vision. So for that, again, these are the things which are the major things which you will write. Again, what is the major thing if this is not being controlled? So for example, this is the drain is affected, right? So you have to remove the clots. So for that we can remove surgery, that is we do trabeculoplasty. But if that is also not working, then you will do what? Trabeculectomy. You will at the end stage, that means you will remove the whole. See, if the water is being clogged, first you will put hot water and you will try whether other things which is present there will clog off. Otherwise what you will do, you will remove the slit itself, so that let us see if everything goes. Again, if that is not being absent, what you will do, you will change the machine itself or change the sieve itself, correct? That's how surgical procedures are. So see, first you will do trabeculoplasty, that is here only you will make some holes. If this is not working, then you will do trabeculectomy, okay. Then again, if this is not happening, then you will change the sieve, that is nothing but artificial drainations, correct? Then to prevent and to have a long-term follow-up, use mitomycin. Understood. So this is how easy it is, provided you link with your day-to-day life, day-to-day activities. In concepts on treatment, I have just explained you again what is happening in primary open angle glaucoma is that to decrease production and to increase outflow, I have just mentioned what are the drugs, mechanism of action of those drugs. So to decrease production, obviously you can give carbonic anhydrase inhibitors and also beta blockers, and both that is to decrease production and to increase outflow you have alpha agonist. Again, to increase outflow we have PG analogs, but these are the major drug of choice for POG. But for angle closure, what is the major thing? It's a sudden block. Okay, obviously for that you have to go with pilocarpine and surgical correction. Again, what is POG is something which is asked, but again with the same thing, again you know the concept. I have given you a real life situation on how POG is. So based on that, in angle closure, obviously everything is closed, correct? So it's an clinical feature goes with intermittent attacks of IOP. So that is something which you need to know. So these are the stages on how it goes. Okay, at the later stage you will have absolute glaucoma. Again, your treatment is, again, what is the major thing? It's pain. Okay. Again, to decrease IOP, so this is what I have given you the concept. Make sure you know it and you present it accordingly and come back. Again, here surgical is again based on how much this thing is there. So again you will go with iridectomy with the laser, or if it's more, then obviously you do trabeculotomy or posterior iridotomy. Absolute glaucoma is nothing but end stage glaucoma. Okay, yeah, you do nothing, but obviously there is nothing, no perception of light, blindfold, blind eye. So obviously you do what enucleation. Again, what are the secondary causes of glaucoma? Again, you will have lens-induced glaucoma. Again, it can be phacomorphic or phacolytic. That means the lens is getting degraded. Okay, based on cataract. So for that you should know the concept of cataract, which we'll be discussing in the further class, in the further section. So based on this, this has to go. Again, based on that, you can have phacomorphic, phacolytic, phacoanaphylactic, and lens particle causing blockages at nothing but the sink is getting. What are the causes of getting blocked by sink? Either some other dust, carrot or radish, something like that. No? So that's how the major thing is. Here based on the lens, what are the causes of lens causing glaucoma is phacomorphic, okay, or phacolytic, that is it getting lysed, or phacoanaphylactic, that might have an anaphylactic reaction or some other lens particle, okay, due to degeneration. Everything remains the same. Neovascular. So what is neovascular? Some vessels are being grown, okay, so that is again causing. These are the causes, okay. Obviously important thing is you have to mention about this. And what is the treatment? Again, you have to stop neovascularization. Obviously for that you can go with photocoagulation and intravitreal injection. We will study in the retina part. And obviously if nothing is working, obviously enucleation. And pseudo exfoliation, again everything is same. But steroid induced, what is the treatment? Again, stop steroid, okay. See, that's how easy it is, provided you know how to place diseases. Again, what does iris Bombay means? That is pupil. Bombay means pulsing out. Pupil is pulsing out. Okay. Why? Because of the pressure. Obviously, you are talking about the lens, glaucoma part, right? So these are the causes, and this is the treatment. Obviously, you have to lower the ITP and you have to give symptomatic management. Again, this is the surgical management, which is the definitive management. Again, congenital glaucoma, major thing is bupophthalmos. What is bup of means? Ox. That is eye of an ox, because of the protrusion, right? So that is one of the cause of juvenile glaucoma. Again, everything remains the same. One thing is you have to remember about R stray, which you need to show them that you know. Again, these are the same thing. Okay. Iridectomy. So what you are doing in iridectomy, it's you are removing the piece of iris to establish a free communication. So this is, if you know, to establish a free communication, you are doing iridectomy. So these are the indication. Prophylactically, in the narrow angle, for example, in a myopic patient, if you have the narrow angle or deep angle, shallow angle, so there you can do it prophylactic, though people don't prefer it. Then again, these are the treatment costs, which I have already seen. Again, by writing complication, again, early post-operative, intra-op, post-op, again the same narration which I have taught in other chapters, again go with the same thing. Okay, mitomycin 3 uses. 3 things. Again, glaucoma is studied, and also one pterygium thing which you have already studied. This is the last topic which we'll study. Okay, that's it. Okay, now coming to disease of retina and choroid. So basically, what is the major function of retina? That is vision. So any topic related to any diseases related to retina, you have to talk something related to vision. That can be also due to optic nerve also. So obviously about optic nerve you can write about complications, okay. Then it's a manifestation of either systemic disease also. So all your systemic disease will come into action here. So these are the 10 marker, these are the 5 marker, these are the 3 markers. So based on this, let us place it accordingly and come back. In CRAO, as I told, again they might ask you what are the causes of painless loss of vision. Okay, in that first thing is CRAO. Again, what are the causes? These 3 important things which you need to mention. And again, as I told, clinical feature, what is the important thing which you need to mention? Visual field. And again, this is something not extra, but this too is important. Again, these are the signs. What is the important thing which you need to mention? Cherry red spots at macula is something which you have to mention. Again, also in the partial occlusion stage, what is cataract appearance? Here, due to sluggishness of blood flow, you might have this thing. This is called as cataract appearance. These are the complications. Obviously, at the end, you can write optic atrophy and blindness. If you don't know anything, okay, at least that you have to write. Again, to investigation, these are the things to evaluate, to diagnose the condition on that. But what is the important thing? One important thing you remember in retina. Retina is a picture of your systemic or a metabolic picture of your whole body in eye. I think I can make a statement. Retina is a photo of your systemic disease. What is CRAO? Again, thrombosis, atherosclerosis. What is hypertension? Systemic. What is diabetes? Systemic. Again, what is retinal detachment? That is sometimes caused, might be due to trauma, and some genetic things also. But this, in an invariable sense, can make sense, provided that for the remembering investigations, I have made a statement like this. Okay. Then again, treatment goals, again, massage thing, it's a controversial thing. Okay, what they say is, since it's just an emboli, you can dislodge the emboli, right? So again, this you can mention, but one thing which I have to mention is isosorbide nitrate, because to cause vasodilation. Again, to reduce the IOP, obviously you go with this. Again, to prevent emboli, again you can start with streptokinase or ILT plus reticulase is something which you do. Okay, that's it about your CRAO. CRVO is not as, so I'm not discussing much about it for your ports. Okay. Then again, coming to your PDR. So before that, let me explain you the concept behind your thing, this thing, because retina takes time, but it's worth investing time because it's all concepts. Okay. So again, I will just give you the concept. Again, what does firstly we'll go with the ETDRS classification, which they say. So basically it has three. Again, I will consider it as basically two, but books have provided it as four, so I just mentioned it. Just remember NPDR and PDR. Okay, this will lead to diabetic macular edema, and this is something nonsense. Okay, just they have provided, so I've written. So what is the concept I'll give you? So first, diabetes affect your capillary. So this capillary has pericytes. Okay. So if pericytes are being affected, so that is called as capillary damage. So what you will have? Microaneurysm. So what do you do? FFA. So what is that? So you will have hyperfluorescent with beaded appearance. This is something first thing which happens. Okay, in moderate things, this is the same thing happens in your 2 to 3 quadrants. Obviously, if this is a circle, how many quadrants? 1, 2, 3, 4. If it's happening in 2, 3 quadrants, it's called as moderate. But for classifying it as severe and very severe, we have something called as 4 to 1 rule. What does 4 to 1 rule says? That is, one thing is about 4 quadrants ka hemorrhage, 1 quadrant ka again intraretinal microvasculature, and obviously if it's an one thing is hemorrhage, then obviously one should be your venous thing, correct? So if it's a venous bleed, so if it's just one, then it's severe. If it's more than or equal to 2, then it's very severe. Why we have made this classification? Just for treatment. Here you just ask them to come for follow-up, but here you will do all your treatment, that is photocoagulation or your all your anti-VEGF, everything you start here. See here I am talking NPDR, remember capillaries. PDR is vessels, that is neovascularization. Again, treatment is what? Anti-VEGF. Okay, and coagulate wherever the new vasculature is being happening. Again, PDR can, what is the major important thing is that PDR can occur again at the disc or anywhere else. So that is called as near the disc or anywhere else. That is neovascularization of disc elsewhere or near to that. So based on that, again you have all these things. Don't remember this, but at least remember this. Again, if this is not treated, again it might go into diabetic macular edema. Okay, so this is the pathogenesis. First capillary damage, then it will affect all those things. Then again, see here I have given again new vessels are obviously by pathology, if you know, it's all fragile and leaky. That will causes microaneurysms and hemorrhage. If this is not being controlled, then obviously it will cause the vitreous hemorrhage. If that causes fibrosis, then what happens? It pulls it back. That will causes tractional retinal detachment. Okay, so it has the same, where studying a disease, study the pathogenesis in a sequential way. So you know the clinical feature. The end part of it is complication. Correct. So this is also a question which we will be later studying. Okay. So now you know how to study that part also. Again, these are the investigations ka aim. Here just you need to know. Okay, there is everything is medicine based. Okay, you are just seeing and you are saying yes, there is neovascularization or there is no neovascularization. FFA is something which you need to know extra. Again, for macular thing, obviously you do ultrasound, that is OCT. Okay. Then again, these are the treatment protocols. Okay, as I told, in NPDR you do nothing. Again, you just ask them to come for a follow-up. But in PDR, obviously you need to do. You have to act aggressively. But again, in the macular edema kind of complication, again what we do, again the major thing is the same thing which you follow. Again, to prevent it. But what is the major thing we are worried about is again vitreous hemorrhage and retinal detachment. If that is there, obviously we have to remove that. That is vitrectomy or planar vitrectomy is something which should in follow-up is lifelong. These are the complications. Again, this is the part of pathogens. While writing any complication in ophthalmology, one thing which you can write blindly is blindness. Okay. Now coming to leukocoria. Again, what is leuco? That is leuco is nothing but white. Coria is nothing but pupil. Okay. So you are getting a white pupil. That is whitish reflex. One thing what all we write is or obviously retinoblastoma. Then again important things which you can mention is about VH and endophthalmitis and also other conditions. In retinoblastoma, they have asked, so make sure you study it. Okay. One important thing is again clinical picture first is nothing but leukocoria. Then it might lead to something is there. What it is happening? What is happening? IOP is being increased. Or obviously we'll have glaucomatous condition. Then obviously we'll have extraocular extension. Then what is the complication? What is the natural history of a disease of any cancer? Obviously our distendment. Again the same thing. Why you are having glaucomatous if you understand? Because there is a growth mass which can increase IOP. So that's why you are having glaucomatous change. So if you know this, then obviously it's very easy for you to come and write any part of the metastatic workup. Okay. One important thing is again in a differentiated I have to mention about this. Again investigation to confirm obviously you have to do all these things, but the major definitive is only by HP, and to assess the disease and metastatic workup, and obviously you have to obviously I hope you know nuts and with hypothesis. Obviously you have to talk with respect to retinoblastoma gene testing also. And these are the treatment things which we have. Again you have okay. In stage 5 also if I'm not wrong. Okay, first stage obviously you go with organ laser photocoagulation, but 2 and 3 we can just give CND, that is carboplatin and etoposide. But in stage 4 and stage 4 something which we do is both CV. Okay, I think even for stage 3 if I'm not wrong, make sure you check it properly. Okay, so this is in general. Okay, but again in last stage that is this with enucleation you have to do, okay, to prevent metastasis. In hypertensive retinopathy, again this concept I will just say you. Okay, that is what is happening again with the vasoconstriction. Again venous is getting affected at AV crossings due to pressure of arterial thickening. This is the concept. Again, these are the phases. Again, vasoconstrictive, sclerotic, exudative. Okay. Again, Keith weakness classification. I don't know how many times they would have asked you in end posting. I don't think there is an thing also for me to discuss. Again, if you cannot remember, this is papilledema, a cotton wool exudates, and this is artery. Again, you have AV thickening and sclerosis. Again, remember the same thing. Place it accordingly. Okay. Then I think all of you know this. Again I think people would have watched Miro how to remember the signs. Again there's a mnemonic which sir has showed that Sallu is keeping gun in bonnet, correct? So you can remember like that. Okay, again grade 4 obviously will have silver wiring of arterioles, and grade 1 obviously what is the important thing, you will have generalized AV attenuation. Again remember, as I told you there, here you will have again since it's chicken and it's compressing it, deflection in the course of vein at AV crossing is Sallu's sign. B for B, banking of veins distal to AV crossing is bonnet signs, and tapering of veins is nothing but gun sign. Okay, one important thing. Then these are the choroid changes which you need to remember. Okay, investigation, again you have to modify the disease. Okay, these are the treatment goals. RD. Okay, so whether the whole retina is getting detached, no, the concept is what? Neurosensory retina and retinal pigment epithelium. When these two get separated, obviously what will happen? You will have retinal detachments. Again, what the basic classification is regmatogenous and non-regmatogenous. In regmatogenous, what is happening? Again, you have a break or tear, so vitreous part will enter. In non-regmatogenous, it's either exudative, that is fluid itself is accumulating, or due to vitreoretinal attraction, you will have non-regmatogenous. Okay, this is the mechanism. And obviously clinical features, since we are still in retina, what I have to talk about? Visual field defect. That is photopsia. That means she will say like the curtain is falling even though there is no curtain falling. That is not photopsia and metamorphosia, which you have to write. In these two things you have to mention. Again, these are the, again you have to mention about Schaffer's sign. That is something which you need to know. And also all these things. Then what is the goals? Obviously first thing is prevention. So how do you prevent? Again, you have to prevent that water going back. So right, you have to identify all retinal plaques and close all plaques. How? Again, via IVG, that is intravitreal injection, or drain the fluid. And if it's already happening, that is, if you want to prevent, what is the important thing which you do? That is pneumatic retinopexy. So what you are doing? So what if you know here you have, it's already detached. So one thing is, by ear you can give force so that this will attach, or by ear you can give force so that this will attach. So by ear, how can you give force? Either by giving air, that is nothing but pneumatic aeropexy, where you will give SF6. Okay, that is room. So that's how, see, again, it's nothing to do with biomechanics, correct? So either you can give ear or ear. If this is called what? Scleral buckling. Either you can do radially or you can do circumferentially, okay, or any to a specific part where you are having. Again, if it's already at the later stage where you cannot do anything, then obviously you go with vitrectomy. That's the major end point of all these things. Okay, that's what we have discussed. Again, if it's post, either this first, then this next. Again, to prevent this, we have discussed this, but if it has already happened, then you have to do pneumatic retinopexy, or else you have to, at the end, if nothing is happening, then you have to go for pars plana vitrectomy. Retinitis pigmentosa, make sure if they ask question here, you might go wrong. They might ask you what are the etiology. It's a polygenic inheritance, which you should know. Okay, again, we are still in retina, so obviously the major thing which you need to write about visual field defect. Okay, this is something which you need to know because it has a AR pattern. No, they might also, this presentation is also common. So these are major things. Peripheral vision is affected first. So what is the triad which you need to know? Obviously arterial attenuation and also bony specules. I am sure you all would have seen that image of black color thing in the fundoscopy, and also waxy pallor of optic disc. Again, these are the visual field defects which you see. About scotoma, you have to mention, and tubular vision also. Again, fundoscopy itself is diagnostic. To assess the severity, we do something of ERG and EOG. We need EOG, in which ERG you will have less PVA. And these are the three symptoms. If it's as a part of trend marker or a 5 marker, might ask what are the three symptoms which are associated with RP. So I have to talk about Refsum's disease, Usher syndrome, and Chiaran-Sager syndrome. This part is not necessary, but if you want to score more, you can write. But remember at least this. Again, these are the differential and these are the types. And treatment goals, again, it's a genetic disease. Obviously, there is no treatment for that, but you can prevent it by giving vitamin A and vitamin B6. And if it's a Refsum disease which is associated, then also this advice you can give. Then already if it has landed in complications like macular edema, then you can go with photocoagulation. Then obviously to improve his vision, if it's already set in, then you can give low vision tests, and also given genetic counseling about test all the brothers. I mean just test all the families. So it's a mostly a X-linked recessive presentation if it's coming in the second or third stage. Okay, genetic disease, no cure, prevention is the main thing. Okay, that's it. Layers of retina, I am not teaching this because from first year histology you are studying, but understanding this, see, cornea understanding was important because diseases are placed like this, but yes, in retina, this you should know. But basically if you know NP and sensory neuroretina, it should be enough to identify all the diseases. So I am not discussing much. Enucleation as a part of 3 marker or 5 marker, they can ask. Obviously you are removing the entire globe with the optic nerve while preserving the orbital contents. Again, it can be either traumatic and non-traumatic. Again, these are the causes. And what is the contraindication? Obviously, on seeing if it's there, then it's an absolute contraindication. And these are the incision which you will do, procedure which you do. If it's self-explanatory, I'm not explaining. Again, neuro-ophthalmology. So one more important thing is, though this is a highly conceptual topic, the weightage is very less. So study only things which are important. Okay. So So these are the questions which they have asked. Again, oh, okay, sudden loss of vision, here they have asked, again painless and painful. If it's painful, something related to nerve. So again, something related to nerve is all this cause. Painless, again, imagine what are the things which is required for vision, place it accordingly, then remember what are the acute conditions which can cause loss of vision. That's it. Papilledema. So one important thing is edema is always associated with infection, but if you don't write non-infectious, you are wrong with your definition itself. So basically mentioning about non-infectious cause of edema in optic disc, this is usually secondary to ICP, is called as papilledema. Okay. Then again, these are the etiology. Again, this is major things which you need to know about it. Okay, then these are the clinical features. Then obviously associated symptoms is something which you can mention. Then again, these are the signs. Again, what is happening? First, retina is red because of this thing. So what is the first thing? Again, venous is getting something which is obstructed. So first thing is hyperemic. Then it will become pale because even mechanical complexion occurs of artery at the later stage. Correct. So first is venous stage. Correct. So there you will have hyperemia and all those things. Then one important things which you need to mention, I am just highlighting champion patch, cork appearance and Patton's line. Make sure you present it. What is the treatment? No treatment. It's just a reference which you get from medicine department to check whether the patient has papilledema or not. So again, basically it's all referred from medicine, referring back to medicine, confirming papilledema is the major management which you do in OPD. Correct. So again, you can mention about all the things what medicine people do in the general things. Okay, now coming to optic atrophy. What is getting atrophied here? Optic nerve. Again, what are the causes here? Again, these are the causes. Again, these are the clinical types. Major thing is primary or secondary. That is, primary is something to do with disease, that is nerve itself, that is in the CNS lesion, is something which you need to discuss. Secondary is again due to some other conditions in eye. Okay, and this is the cause of optic neuritis. Okay, so to understand optic neuritis, anatomy of optic nerve or course of optic nerve is something which you need to know. Okay, and these are the causes. Again, these are the signs. How do you manage it? Again, itis. If you don't know what to do, what you will give in things? Steroids. Again, to improve now, because it's something to do with myelination, you can give methamphetamine. What is retrobulbar neuritis? So again, it's a retrobulbar part which is getting affected, anatomically speaking, but historically speaking, what they saw was patient had a severe loss of vision, but when fundus was examined, it was normal. So when they traced back, then they came to know it's something to do with retrobulbar neuritis. So again, these are the causes and these are the signs. Then treatment, again, neuritis, right? So obviously I have to use steroid. Aidis pupil. This also has an historical context, so I've just returned it. So what happened was, different size pupil, when they performed angle, that is deep tendon reflex, they had different exaggeration. So they thought something related to, there's some connection related to that. But what was the connection? This was basically at ciliary ganglion, they had some lesion. So that was the basic connection which they wanted to try, which they tried to find out. So based on that, these are the causes which we have. So this is the treatment. So what is the major thing? It's a reassurance. Again, to have proper near vision, you can start them on low dose pilocarpine. That's it. Okay. So that's how, when you are struck, only two things will help you: knowing the real natural history of disease with the pathogenesis, or history of the disease and how they found out, so that 90% of your things will be sorted. Again, RAPD or Marcus Can pupil, again what they found out, again when they flashed the light, the other part dilated, but when they flashed to the disease eye, what happened was it didn't dilate. So basically, what was the cause? That is, less perception of light was the something which they found out. Again, these are the causes. Okay, something related to CNS and PNS. Divide it and place it accordingly. In tubular vision, again divided into organic and non-organic. In that, you have to write about malingering, and these are the organic causes. In nyctalopia, I know in and out you would have studied. Again, basically you have to write about vitamin A deficiency at first, even though that has been reduced. Then you can mention about RP major clinical presentation in nowadays is nyctalopia itself. Then malabsorption syndrome. Based on this also you can mention. In nutritional amyloidopia, again these are the causes and these are the clinical features, and obviously management will do. Hemerolopia is day blindness. So what is getting here affected? Cone is getting affected. So these are the causes. Again, cone is affected, so cone is having dystrophy or uncorrected myopia or retina toxicity. Color blindness, from physiology you are studying, obviously I think it hasn't. I hope you will learn it accordingly. Again, testing of color vision. Okay, here I think basically you go with FM100 or FF15, and also one more confirmatory thing is there which I'm not remembering, but basically for screening what you do is share a chart. Again, for children's, you ask them to read about stars or circle part. So this is the screening part and this is the diagnostic part. And also for railway workers, railway workers, that is drivers, they'll ask you to identify red color and blue color. There's also one more name for it, so make sure you study that also. These are the testing which are available for color vision. And RS2 type of question for 3 marker. Again, these are the tests for malingering. Again, obviously if when you see them you can identify, but basically if they are malingering you will understand by following test itself. Okay. Now these are the ocular signs also in head injury. Basically I have to write about these things. Okay, that's it. Now diseases of lens, again cataract, and these are the important questions here. Basically what they are expecting you to know is about the surgical part of cataract. And this is an important 3 marker. I don't know how many times they have asked. In cataract, I don't think I need to discuss about classification. I'm sure you know about it. And again, the major thing is about the senile cataract, for which you need to know the pathogenesis. Again, these are the stages. Okay. Again, you might have, you all know cortex and nucleus is something which you know. Again, you might have the cortical fibers which are getting separated by fluid. Again, you might have cuneiform cataract or a cupuliform cataract based on how it looks. Then again, at the later stage, it will become immature cataract, after which it becomes mature cataract and it will become an hypermature cataract. So that's how it is. And these are obviously clinical feature. What is the major thing? Lens is getting affected. What is the function of lens? One is to provide vision. Correct. So obviously I have to talk only about the visual symptoms. Again, these are the investigation steps. In and out you have to know. Again, major thing is you have to, since it's a surgical thing, obviously surgical examination workup also you can do. And also you have to check whether associated conditions are present which can affect vision, so that before surgery itself you take the consent and make sure you are safe. Okay, so that investigation ka part also you can present it so that you are legally safe. Okay, surgically safe, legally safe, and patient wise safe. That's how broadly I remember. And these are the medical thing. Again, obviously the major thing is to correct the refractive errors. Then these are the surgical things. I'm sure in and out you know. Okay, again the principles I'm not discussing. Again, causes of congenital cataract. Based on embryo, if you study, obviously you will know how the types goes. In the same thing. Okay, complication of cataract surgery, again related to anesthesia, operative, and lens related. Make sure you divide it accordingly and then place it. Okay, again anesthesia, obviously if you are based on you might have xylocanalgia or irritable hemorrhage. Again operative, how did I taught you? Again intra-op, stop. Again intra-op, again these are the things, and post-op, again infectious and secondaries. Again latest, again you have to talk about all the diseases, which majorly all the important diseases which we will discuss. In lens related, again you might have or the related complication. After cataract is what? Again, after performing a cataract surgery, if she has opacification, that is called as after cataract. Okay, these are the causes. If that becomes swollen, then it's called as L-string pulse. If it's left at periphery, then it's called ring of Sommering. Then if there is a fibrotic thing which is present, that is called as fibrotic membrane. In what you will do, obviously go with a laser. Again, complicated cataract, again it can be either due to degenerative thing or inflammatory thing. Again, clinical feature remains the same, but one important thing is, again you have to treat the underlying pathology, without which even if you do cataract surgery, there's of no use. And IOL, for 3 markers they might ask, the nature of topic itself is self-explanatory, so make sure you know that. But important thing is you need to know the SRK formula. So what is the aim of SRK formula? To check for what IOL you have to place, power of it. Okay, so for that you should know where are the refraction where and all refraction occurs. One is at the cornea, Now about the axial length in eyeball. So what is the formula? A minus 2.5 L minus 0.9 K. So what is A? A is the constant by the manufacturer. What is L? L is nothing but axial length of eyeball, and K is the corneal power. Okay, this if you want you can remember, but I would say don't remember. And hyphema, that is something to do with blood in anterior chamber. Again, if it's blood, what is the important thing in the surgical paper? Traumatic, non-traumatic, that's it. And again, these are the complications. Again, what is the major thing? Obviously, you have to prevent IOP and also prevent everything. Refractive errors. I don't know from 6th standard are we studying this? These two things, and one more is presbyopia. Yeah. So they have already changed. So the important thing which they ask is about astigmatism. Okay, but remaining things are also important. But I'm not touching on those 3 topics because I don't think explanation is required. Okay, so that you can study on your own. Again, these are the etiology. Okay, these are the types. Again, what is happening here? We are talking about lens. Major thing is about lens only, no? So what is the important thing which in clinical feature comes in? Visual symptoms. Again, this is short remark. I mean important remark. So every named work is important here. Few spots. Okay, myopic crescent, posterior staphyloma, snail tract degeneration. Okay, these all are important. So basically, what is the funda? It is getting stretched. If you know that fundus is getting stretched, then based on that, if you know how the whole stages goes, how everything gets affected. For example, how optic disc is affected. Then what is the next thing to that? There's a macula. How is it getting affected? How is the peripheral retina getting resented? So make sure you know the major rating. So based on that, you just stretch. Even if you forget everything. Okay. And again, these are the investigation. I'm not talking anything as I have told you. From NCRT you are studying this, but important thing is basically about surgery. You should know when after only 17 years you will do the surgery. These are the things which are the options which you have. Again, this is the LASIK. I'm sure you know. Again, what are the uses of indications of contact lens? Again, why will you use in keratoconus? What kind of lenses you use? Rigid lens. Okay, these are the complications. Hypermetropia is also something which you know. Okay, astigmatism is something I will just touch up on it because it's something which we are not studying from 6th to 8th standard. So what happens is the ear, based on the direction, you have a refractive error which is getting different in different meridian. Okay, so either you might have, so basically what are the 2 meridians we have? We have horizontal meridian and vertical meridian. So based on what is more, whether VC is more than HC or HC is more than VC, we have different astigmatism. Okay. So again, these are the types. Again, you have simple astigmatism or compound or mixed. Okay. So simple is either myopic or hypermetropic. Compound is at different angles. Okay. But mixed is both. Again, forms basically with the rule and against the rule, which I'll be explaining, and these are the treatments. So what happens is, so if it's with so for example, if this is the eye, so think if cornea is flat. Okay, so if horizontal meridian is greater than vertical meridian, then cornea goes inward. So that is against the rule astigmatism. What does with the rule astigmatism means? If vertical meridian is more than horizontal meridian, that is upper and lower eyelids are pressed. So if you have to write, then first thing is you have to write W. So if vertical meridian is more than horizontal meridian, that means it's getting upward and lower eyelid is getting pressed, then it's with the rule astigmatism. Please remember that. Okay. So based on that also, again, these are the things. Again, what do you do? Cylindrical lens. So many things I'm sure you can explain. This is the concept. So based on that, you can do. In presbyopia, I'm not discussing at all. But this treatment part, I am sure you just add 0.5 to everything based on age plus 5.5. That's it. Aphakia, again, absence of lens in pupillary spaces. Aphakia, again, you can do it or trauma can do it. So these are the treatment aims. Okay. Enough. Okay, I'm going in a hurry because there are remaining things which we also need to discuss. Again, diseases of eyelids. So what was happening again? If you understand from 0 AD to 2025-26 AD, first things which were killing humans was infections. So here if you see in eyelids, you see all these names: blepharitis, entropion, hordeolum externum, chalazion, symblepharophon. All these are Greek words. So what does it implies? These are old disease. Okay. So English words are less. So it's ancient disease. So this is how it is. So firstly we'll know what does all the names mean. So what does our hard callosian means? Callosian means small lump. So what does hordeolum means? Barley grain. What does blepharitis means? That is eyelid is getting inflamed. Okay, what does entropion means? That is inward turning of your eyelashes. Okay, so now you have an etymological meaning. So now we will go and dive and discuss it again. The same thing what is infectious protocol which you need to follow. Blepharitis, what is inflammation of lid margin. So these are the types. Okay, these are the clinical features. Obviously we are talking about infection, obviously we have to talk about inflammation gas sign. Then again you might have visual things. Okay, the examination findings. Okay, treatment, obviously reduce the symptoms, treat it, treat secondary infection, and restore and prevention. That's it. Entropion, again majorly you have to remember about senile thing. Okay, and also it might be due to either spastic thing or cicatrization thing. And these are the same grading and also the clinical feature, and also senile thing is something which they will ask. Here you have to do surgical correction of it. Okay, so these are the things which needs to be maintained to prevent an entropion ka formation. Entropion ka formation. Okay? These are the things which you do to make sure that is correct. In causes of ptosis, which they might ask again, what are the three things which has to be there? Again, LPS muscle ka stability, Muller muscle ka stability, and frontalis is affected in the severe to moderate to severe disease. So you need to back up for that. Again, these are the it might be either due to congenital and acquired. So if it's an acquired condition, again, what is the first thing? Again, nerves. So third nerve palsy or myogenic like these conditions, and also mechanical. This is the post-operation. Obviously, you have to. This is the treatment. Lag of thermus, that is leg is getting like. What is the first thing which will be thyroid? And also about Bell's palsy. So again, here you have to prevent complication, which is there as I told. And lateral testorophy is something which will do. Symblepharon, what is that? As I told, symblepharon, did we discuss what does it mean? Etymology of symblepharon is adhesions between eyelids and eyeball. Okay, so they are saying there's an adhesion between eyelids and eyeball. So what does it mean? Okay, so either you might have anterior adhesion or posterior or total adhesion. So again, prophylactically, how you can prevent is by giving an eye ointment or surgically excising. These are the surgical things which you do. Hordeolum, that is barley-like grains in the internum, that is inside, that is due to acute suppurative inflammation of meibomian glands. Okay, then obviously it's same thing. See, but one important thing in callosian which is different is incision and keratitis with lemon blade. Though it's a chronic glandulomatous inflammation of meibomian gland, that is C for C. One thing which you need to remember is, okay, again refractive error. I have told the concept against the rule astigmatism because you are getting pressed to both side. Okay, and audiola externum is also called as sty. Remember sty as ZTY so that you know which gland is also getting involved. Again, same infectious protocol. TARS or FE, again you are lifting it up. So again, it might be due to treatment protocol or as the prophylactic or in temporary things also. Horner syndrome, 3 mark they might ask. Again, triad of meiosis, ptosis and anidosis, which you need to remember. Lacrimal apparatus, again it's a 5 mark or a 3 mark thing which they can ask. But Jones type test RS2 type of question, but I don't know, they might ask you. But just remember, again, these are the things which they can ask for 3 mark. Okay, so I think if you are in pediatrics posting in a neonatal thing, I think many would have seen this case. Again, what is the major thing? Major treatment plan which you do, that is you have to do a massage. You have to say them to do massage in morning, afternoon, and as well as night. Okay, if nothing is happening, then you probe NLD. Then if that is also not happening, you can go for syringe. In acute dacrocystitis, that is if it's getting infectious, it is called as acute dacrocystitis. Again, same infectious disease thing you can just write. Again, same thing, what are everything which is there, but one thing which you miss is cavernous sinus thrombosis. So make sure you write that out. So again, to control infection and to prevent complication, these are the things which you do. In chronic dacrocystitis, again major, if it's a chronic, what is the major thing? Again, surgical thing which you do. What is that? This dacrocyst or inostomy is something which you do. Again, these are the conditions. Obviously, if this is happening, what is there are some secondary pathologies like anatomical abnormalities is something which you need to think about. So based on this, obviously we need to think about chronic dacrocystitis and place the disease. Again, these are the clinical features which you should know. Again, now as I have told you, again treatment, again which is the major thing to go for DCR. Again tear film, again just remember mal. Okay, thing is, see, you have to prevent evaporation. So for that, which is the best insulator to prevent evaporation is lipid. So outer layer has to be lipid. So based on that, again you will have water obviously to prevent evaporation. Then below that you have goblet cells also to provide an easy, because something, for example, think it's like a plastic. For that you need to have a lubrication. For that you have mucus. Then you have a water. Then to prevent evaporation, what you have? You have a lipid layer. Okay. In causes of dry out, it's an important thing. Again, MAL, due to mucin deficiency or aqueous deficiency or lipid deficiency. Again, if it's not getting closed, for example, in Bell's palsy and lagophthalmos, that can also cause dry eyes. And these are the miscellaneous causes. Again, what is the major thing which you need to think? You have to evaluate for exposure keratitis, for which you will do fluorescein or rose bengal thing, and you check for ulcer also. Again, these are the treatment which you will do. Again, major thing is you have to prevent complication, and also these are the things which you will do to increase ICA secretions also. Again, indications, I think this, if you read also, you should be able to understand. Again, uveitis, important thing here is you should know what are the things which is there in uvea. Obviously, it's ciliary, iris, ciliary body and choroid. So again, basically what important thing is, it's an autoimmune conditions which will affect uvea mostly. Then important thing is bacteria. Then bacteria almost equal to trauma. So if you know this, then you know how to place clinical feature, how to place investigation, how to basic management also. But what happens here is, again, these are the differentials for red eye, I'm sure. Again, remember what is the first layer? Conjunctival. Next you have cornea, then you have lens, then you have uvea, then you have lens, then you have uvea, then you have posterior part is sclera, because that is what we are discussing. Then basically, if it's a surgical topic, traumatic, not traumatic. And this is the classification. Again, this is the anatomical thing which you can just remember. Again, what is the important thing is, here you are having inflammation, so you have to write about lacrimation first. Again, it's an inflammation. Again, rubrical tumor is something which you can write. Again, visual symptom is getting affected because here the lens, again the iris part is nothing but the ciliary body holds the lens, so even visual fields can also get affected. But important thing which you have to write in and out is these things. Okay. Again, you have to write about all the keratic precipitates which can be seen. Again, mutton fat keratic precipitates in granulomatous disease, and in non-granulomatous disease you can have small or medium. Then also if it's red, obviously due to hemorrhage. And also in old age disease, also something which you can write. Again, while writing about anterior chamber, again you have to write about all these things, hypopyon, from everything is important, because if they are asking you a question of uveitis, they are testing you whether you know the clinical signs in a uvea. That's the main aim when they are asking a uveitis based question. So make sure you study full of it. And again, while writing iris sign, again cope, again where is pupil, it's a side thing. Again, if it's side at the pupil, then it's Cope's nodules, and again if it's diffuse, then it's Busaka's nodules. Okay, you have to write it. Again, what is the major aim in the uveitis question? Science, and you have to differentiate based on science whether it's an granulomatous disease or a non-granulomatous disease. Arrive to a conclusion whether it's an autoimmune or non-autoimmune based on the two investigations and two treatment. In these other pupillary signs, I have highlighted all the important name things which they expect you to know. So based on that, underline it accordingly, then place it. And these are the investigations which you need to do. And these are the treatment aims. Because it's an intense pain, obviously you have to write about cycloplegic and mydriatics, and also NSAID and steroids. It's a systemic therapy in autoimmune disorders. You have to evaluate aggressively and find out what is the etiology. Endophthalmitis, again, if the whole of the retina and vitreous is getting inflamed, that is called as endophthalmitis. Again, it might be basically surgical or an infective thing. That is majorly, if you, I think even you know about TAS also. Okay, that is almost equivalent to, not equivalent, but a part of a subset of endophthalmitis. Clinical feature is same. Again, this is the mainstay. Okay, but these are the supportive treatment. Again, so three syndromes which can be associated with uveitis, Behcet-Lethal, VKS, and Peter syndrome. You can just remember it. If you don't study community ophthalmology and go to an ophthal exam, roughly, you are writing a paper for 90. Okay, that is the importance of knowing community. Sure, 1 5 marker and 1 3 marker is a sure question. Sure. So make sure you study everything accordingly. Don't come to a conclusion that you know community medicine well. No. Here there are, again, it's you are having some peaks overlap also. For example, in vitamin A and glaucoma also, and also some things, child blindness and all those things, you have a pediatric overlap. But also you need to study because it's a short questions, and that day you have to just know things and you have to come back. Okay, these are the questions. Again, what are the cause, what are the type, definition of blindness is different for different people. Again, you will say legal blindness only when they're in legal blindness, this is the refractive thing which you need to have, then they're eligible for all the welfare measures. And what is social blindness, that is less than 3/60. And what is economic blindness is less than this and this almost equal the same. Okay, but also you might have manifest and obsolete blindness. This just to know what are the types of blindness I have mentioned. Again, what is childhood blindness, these are the major causes which you need to write. Okay, cataract. Okay, again, these are the management. Again, where are we are in community medicine. Obviously I talk about prevention. Again, primary prevention, second prevention, tertiary prevention. So place it accordingly, come back. Okay, again, DBCS, I'm not explaining because there's nothing for me to explain. You have all past community, so I've given you the notes. If you want, you can study park, I don't mind, but you make sure you study, but don't miss this topic. Okay, even NPCB I have not written properly. Okay, please make sure you go to refer some book and write, because even I felt bored while writing this. So many objectives there, and when they're asking 2025, in 2025 they're asking about vision 2020. I don't know, they didn't achieve, as a government they failed to achieve all those objectives, but they are expecting us to know in 2025 what were the objectives in 2020. Foolish shit. Okay, and also, I don't know what to say, but these are the questions which is coming. But since we are in this university, we need to study. Wow, these are the objectives which they have. I don't know how much they have achieved. At least we have to be happy that WHO has declared as this trachoma free. Okay, please study. Then I cannot do anything, right? And this is how you rehabilitation of blind. Obviously, one thing all we remember is about the job rehabilitation, and also have to give occasional rehabilitation and braille system, because they need to study. And if possible, if there are any medias where you can provide them vision, obviously you need to talk about that also. And vitamin A classification, it's a very important thing. Obviously first you divide it into primary and secondary. Again, secondary, these are the signs which you remember NFS. Again, night blindness, then xerophthalmia due to fundus and due to scarring, because this is the latest stage. Again, X1, X2, X2, what does X stand for? X stand for xerosis. Again, you might have, based on, again, this is anatomy. Again, first, what is the first layer of eye? That is conjunctiva. What is second? Cornea. So based on that, how much it is getting involved. Again, what is the first thing? Again, xerosis. Again, if it's based on the third part is about ulcer. If it's less than 1/3, it's A, and more than 1/3, it's B. That is not keratoplazy. That's it. Treatment. Okay, treatment, I will just explain you the concept. So concept is, so your liver also has vitamin A ka, what do you say, storage. Yeah, so while giving a prophylaxis in a 6-month-old side, liver can store only 50,000 international unit, but in a 6 month to 1 year, obviously capacity increases from 1 lakh international unit. But if it's a 1 year to 6-year-old child, then obviously the capacity increases by 2 lakhs international unit. But while for a lactation mother, since she can also ingest vitamin A, this is the prophylactic dose which we keep. Okay, but If it's a treatment based protocol, this is the dose which you have to give, that is 2 lakh international unit, which is roughly equal to the same prophylactic dose which you give from 1 to 6 year, because the capacity of the liver, that is storage form, is also something which you are treating. It's the same. Okay, then why are we giving it 0.14? Because 0 is to make sure that vitamin is going to all parts, and 1 is to make sure that other parts which is not got 0 due to some other infection or inflammation, that is getting the same vitamin A, and 14 is for storage. This is the concept. This is the pharmaco kinetics or pharmacodynamics of the vitamin A, why you will give. Okay, I've explained you because it's important to know. Okay, I've explained you topics which has to be explained. I will not sit and explain community. Please don't expect me to explain that also. I'm not made to do that. Again, same, I don't know, even in ENT they ask about ENT manifestation in age. So I thought even retinal lesions in age is also important. Again, it can affect retina, the major thing. Okay. Again, you might have retinopathy or CMU retinitis. I'm sure all these are MCQ, all would have heard this. Just an one time view should be enough. Again, how do you preserve the donor cornea? These for short term, intermediate term, and long term. And these are eye bank function. This is an easy thing. So just if you know what are the steps which they follow, then I think it should be enough. Again, orbital disease, again the major thing which you talk about is injuries or trauma. Okay, and these are the chemical part. This is just a 3 marker thing. Okay, 3 marker or 5 marker. So I'm not presenting explaining also things which are much things, because also it has an important things. Again, you treat infection, irrigation, and remove irritant. Again, you don't give alkali because it's an exothermic reaction. Okay, and blunt, again you might have open globe injuries or closed globe injuries. Based on that, all things based on how it gets affected, I have written. Please make sure you study it. Okay, again this is something to do with endophthalmitis due to copper excess. Okay, traumatic cataract, I have to mention about this. Orbital cellulitis, again cellulitis of the orbit. Major cause is Staphylococcus. Obviously this you have to address, and also antibiotics is something which I have to mention. These are the complications which you can mention. Make sure you mention this. Intracranial is major. Okay, this is the treatment. Proptosis, I don't from thyroid, from surgery also you can study. Wherever you feel easy you can study, but these are the causes of bilateral proptosis. That means whenever anything is bilateral in medicine, what does this mean? It's a systemic thing. Okay, so obviously by this you should be able to understand all the etiology part of it, and also these are the causes. Obviously you need to protect the eyes, so for which you give this, and also to correct it you can go with this. Again, 3 markers for 3 lid signs. Again, for 5 markers they are asking surgery, so you can study it there. Again, you have to write about one graph sign, Kutzer sign, and cell vaccine, but all signs with all the explanation is something which they expected to know. Again, blowout fracture, again in ENT would have studied, but again make sure you mentioned it. Okay, again ABC is something which you need to mention. Again, these other things. Again, sympathetic ophthalmitis, what you are doing, again you will remove out the eye so that the other eye which is there is being preserved. Okay, and you give steroid. Again, scleritis, again it's a 3 marker thing. Okay, basically what they ask is episcleritis and a cilitis. What it's a, again it's a marker for your autoimmune thing. Okay, again the types you just remember, either it can be diffuse or nodular. Okay, and whenever you see this, what is that? Something you are doing with chronic inflammatory disease. Make sure you study it. Okay, but what is the important thing which you know in episcleritis? You also basically in all these things always have what in mind? Okay, that is something which you need to know. And staphyloma, obviously I think the name itself is a self-explanatory. I'm not going in depth because it's a 3 marker topic. I don't want to waste your time right now, but these are the causes. Again, this is something to do with anatomy. If you know, you will already understand. Again, strabismus, it's a 3 marker topic, so I'm not discussing much. These are the important things which are important. In this probably 3 markers, see, pray if you get this under strabismus, because it's something which is easy. Again, just make a box, you place it, again write about primary action, secondary action and tertiary action. Now supply, just remember this. I'm sure from anatomy you can just manage. In paralytic squint, again there is a paralysis because of the paralysis of extraocular muscle. Again, if there's a paralysis, again write about associated and visual symptoms, and obviously you need to mention about all the tests. Okay, here again, knowledge is something being tested. Okay, this please make sure you know it. Okay, these are the way how do you treat it. In amblyopia, that is loss of vision. Okay, again the major thing which you need to know is how do you prevent it. Okay, again nystagmus, again you should know what are the types, and these are the, this can be an independent 3 marker. Okay, paralytic and non-paralytic, make sure 3 or 6 points you study, 3 of clinical feature and 3 of examination findings, and 1 example. If you write, you should fetch 3 marker or even 5 marker also. Okay, so that's it. I have to talk about ophthalmology. With that, we have completed the ophthalmology. But what is the major important thing which I want you to know? Make sure you know the general things of a general thing. For example, if you are studying about conjunctival disease, you should know what are the things which you need to write on the clinical feature of conjunctival disease and what are the diseases which are there in conjunctival. Okay. So it can be either an infectious disease or allergic disease, and also if it's bulge, some fleshy mass is there, then there's something to do with the region. Then what about cornea? First you need to know the layers of cornea and what are the diseases which are present. 2-3 diseases, again infectious thing. Glaucoma, obviously because of IOP. What are the things? I think it's an optic nerve issues which is getting thing. Again, disease of red and retina and choroid. What did I say? It's a picture of systemic disease which is being reflected as a part. If it starts to show in eye, it will show in retina. And also some genetic conditions. Eyelid disease, what is the important thing? It's an old age disease, so all Greek Latin names comes there. Refractive errors in and out from 6th standard, 8th standard you are learning, so I have not touched except presbyopia, which is an important 5 marker which they are asking in the recent days. Again, lacrimal drainage system and tear film abnormalities, again these are the 3 marker questions. Again, DCR indication and surgical things which there is something which they are asking. In diseases of keratitis, episcleritis, if we know more than enough. Diseases of lens, again all the cataract thing, that is surgically part, if you know it's more than enough. Uveitis, again the major thing is whether you are able to identify the clinical feature and whether you are able to know the signs of all the things. Based on this, whether you are able to differentiate whether it's something to do with autoimmune or granulomatous or non-granulomatous, arrive to a conclusion, arrive to an investigation and diagnose and decision and come back. If you know that it's more than enough. Arbitrary disease, majorly it's all the dramatic things which they expect you to know. Neuro-ophthalmology, nothing much. Obviously you have to know about major important things, for example, which painless loss of vision and all the important things which I have discussed. Again, community, most important topic. You should study a day before exam, objectives, principles, and also treatment goals which they have. And strabismus, pray you get UM. Because paralytic, again, if they want to ask about paralytic, non-paralytic, other questions, only paralytic and non-paralytic squint. That's the only important thing. See, that's how. So if you have a proper orientation of the subject, now if you go and study, now if you want to add points to these notes, make sure you take a Xerox and you add important points to that place so that you know what are the things we need to study extra. So this is what the general understanding which I wanted to give about the subject, about the pattern, about the adjectives which they expect you to know. Based on this, you build upon on what you have to add and what you have to remove. If you want, you can definitely remove. So based on that, make sure you study this part. Okay, make sure our revision, obviously 2 to 3 revision is must, but a day before exam I expect you to do this revision so that you have a proper, even a day before exam, before you sleeping, you already have the paper in mind so that you know what are the things which they can ask, so that you're already prepared for tomorrow's paper so that you can sleep peacefully. Okay, that's it. I hope I have done justice to this subject. I wish you the best. All the best.